Hey guys, it's the MedStudier, and today we're going to be looking at hypertension, including its basic pathophysiology as well as some of the clinical management steps. Hypertension, or otherwise known as high blood pressure, is a common condition that rarely shows any noticeable symptoms. However, if untreated, this can increase an individual's risk of heart attack and stroke. Around 1/3 of the UK's population is known to have hypertension. But how do we clinically define hypertension? Well, this is when an individual's systolic blood pressure is over 140 millimeters of mercury and their diastolic blood pressure is over 90 millimeters of mercury. There are two main causes of hypertension. Firstly, essential hypertension is common in over 90% of cases. This means that there's an unknown or unmodifiable cause for an individual's hypertension. Therefore, this is usually due to a huge range of factors rather than a specific cause. Whereas in secondary hypertension, there's usually an identifiable cause, and this is present in around 10% of cases. Here, the causes include renal dysfunction, endocrine disorders, and pregnancy. There are some factors that can increase your risk of hypertension. This includes if you're over the age of 65, overweight, if you're of African or Caribbean descent, have a family history of high blood pressure, eat foods with high salt content, don't exercise, drink alcohol, smoke, or even if you don't get enough sleep. Therefore, often making lifestyle changes can help to improve your blood pressure so that it reaches a healthier value. In order to understand how to approach this scenario, let's have a look at an example case. So here we have a 63-year-old Caucasian male that comes to your GP clinic and is found to have a blood pressure of 166 over 103 millimeters of mercury. Then a repeat measurement was later collected as 165 over 102 millimeters of mercury. The patient also has no drug allergies. So what would be the first line of investigation and the management for this patient? So the primary investigation for a patient like this would be to check their blood pressure again. And if the value lies between 140 over 90 to 179 over 110 millimeters of mercury, then we would offer an ambulatory blood pressure monitor. So this is just a device that the patient would have in order to measure their blood pressure over a period of 24 hours. However, if this is not tolerated by the patient, or if they are unable to have the device, then we would offer home blood pressure monitoring. But what happens if the patient's blood pressure was recorded to be above 180 over 120 millimeters of mercury? Well, this is a dangerously high blood pressure reading, so we would consider drug treatment as well as assess the risk of target organ damage. When the blood pressure is increasingly high and above 180 over 120, then we'll need to investigate the patient for potential organ damage. Examples of this include fundoscopy in order to assess for hypertensive retinopathy. Albumin and creatinine ratio is needed to ensure that there's no renal dysfunction. A 12-lead ECG to check for evidence of left ventricular hypertrophy or even an MI. And finally, blood tests would also be needed in order to check for HbA1c levels and cholesterol levels, etc. The Q-risk ratio is also often used in order to estimate the potential risk of a cardiovascular event over the next 10 years. So this includes a myocardial infarction or even stroke. So now let's have a look at what sort of anti-hypertensive drugs would be provided to these patients. According to the National Institute for Health and Care Excellence, the treatment can depend on the patient's potential risk factors. So firstly, if the individual is below the age of 55 or has hypertension with type 2 diabetes, they would be started off with ACE inhibitors like Ramapro. An important thing to consider here is that often ACE inhibitors can cause extensive coughing, and hence these patients can also be provided alternatively with angiotensin receptor blockers. On the other hand, if the patient is above the age of 55 or is of Afro-Caribbean descent, then they would be started off with calcium channel blockers. So for the purposes of this diagram, let's call this B. So that concludes step 1. And step 2 would be to combine the drug regimens. So if they already have A, then we would add on B or a thiazide-like diuretic. Similarly, if they are on B, then we would add on A or a thiazide-like diuretic. And finally, in step 3, if the patient is still persistent with hypertension, we would add all the drugs. So A plus B plus thiazide-like diuretic. So now let's have a little summary about everything we've discussed so far in this video. So firstly, we had a look at what is hypertension. Then we moved on to the causes of hypertension, where we looked at essential and secondary hypertension, as well as the various risk factors. Then we had a look at an example case in order to contextualize our learning. This then helped us to identify the primary investigations, as well as how to assess the potential risk of target organ damage. And finally, we had a look at the stepwise approach in order to provide treatment management options for the patients. And that brings us to the end of this video. Hope you guys found it really useful. Remember to like, subscribe, and comment below. And follow me on Instagram at the MedStudier.